Hi, welcome to the Smiles for Life virtual training, an early childhood caries prevention initiative focused on integrating oral health into well child visits. I am Dr. Hugh Silk, family physician at the University of Massachusetts Medical Center and lecturer at the Harvard School of Dental Medicine and a founding author of Smiles for Life. Addressing oral health in primary care is important especially for young children who have not yet seen a dentist. Children are in primary care offices for multiple well child visits, and this is a unique opportunity to initiate preventive oral health and parent or caregiver counseling on healthy behaviors. Nationally, early pediatric oral health in primary care has become the standard of care for all children. This training includes Module 6 Caries Risk Assessment, Fluoride Varnish, and counseling. This is a national curriculum endorsed by the American Academy of Family Physicians and the American Academy of Pediatrics, as well as many other national organizations. At the completion of this training, you will receive 1 CME credit once you score 80% or higher on the assessment quiz following this video. This training will focus primarily on caries prevention. It offers a brief review of early childhood caries and addresses how the use of fluoride is part of a comprehensive approach to a child's oral health. Specifically, clinicians will learn the benefits, appropriate safety precautions, and dosing for fluoride, as well as how to apply fluoride varnish and provide adequate follow-up care. We hope you find this training helpful in bringing oral care into the medical home setting.
Hello, I'm Susan Cody, Program Manager from The First Tooth. The objective of this training is to include the prevalence, etiology, consequences, and prevention of early childhood caries, also known as ECC. We will show you how to perform an appropriate oral examination on small children, how to perform a caries risk assessment, including reviewing a specific tool, and the effects, sources, and benefits of fluoride varnish. We will conclude with a short demonstration video on the application of fluoride varnish and tips for using varnish in the office. Early childhood caries is a chronic disease that destroys tooth structure that leads to loss of chewing function, pain, and infection in children up to 5 years of age. ECC is defined as the presence of one or more decayed, missing, or filled tooth surfaces in any primary tooth in the preschool-age children between birth and 71 months of age. ECC was once called nursing caries or baby bottle tooth decay. Now the disease is called ECC as a variety of feeding habits are implicated. Other known variables include socioeconomic status, access to dental care, fluoride exposure, and family caries experience. ECC is a public health crisis and the most common chronic disease in children. It is 5 times more common than asthma. Nationally, 35% of low-income children have ECC, and about 23% of children aged 2 to 5 years have it. Rates of ECC are even higher in Hispanic and Black children. Many cases of ECC go undiagnosed, usually because parents or caregivers do not seek the dental care at an early age for their children. Clinicians play a major role in preventing ECC and initiating early treatment. Dental caries is a multi-step process that results in the destruction of tooth structure. Oral bacteria, primarily mutans streptococci and lactobacilli, metabolize the sugars from dietary carbohydrates into acid. The acid then demineralizes the tooth enamel. If the cycle of acid production and demineralization continues, the enamel will become weakened and break down into a cavity. We know that it's not just what children eat, but how much and how often they eat. Oral bacteria produce acids that persist for 20 to 40 minutes after sugar ingestion. Oral acids then lead to enamel demineralization. Remineralization occurs when acid is buffered by saliva. If sugars are consumed frequently, there is insufficient time for the remineralization process to occur. The tooth is subjected to continued demineralization and the process of caries progresses. So, if a child has meals, snacks, and ongoing access to sippy cups with juice, he or she may remain in the danger zone for hours on end. ECC has many potentially severe consequences, such as pain, impaired chewing, poor nutrition, infection, and increased caries and permanent dentition. Students with dental pain are almost 3 times more likely to have poor school performance. Children may have difficulty sleeping and poor self-esteem. Treatment is extensive and expensive. Dental work in children must often be completed under general anesthesia, which carries a higher risk.
Hi, I am Dr. Jennifer Dubale, pediatrician at Maine Medical Partners in Portland. I'd like to show you how to perform an appropriate oral examination on small children and recognize various stages of ECC. Small children are best examined while lying down. For infants and toddlers, the knee-to-knee oral examination allows you to carefully examine the child's teeth with assistance from the caregiver. If the child's legs don't fit around the caregiver's body, the child may lie sideways or diagonally on the caregiver's lap. To conduct the exam, the child is in the caregiver's lap facing the caregiver. The healthcare provider brings their knees up to the caregiver as in the first photo. The caregiver lies the child down onto their legs and the healthcare provider's legs. The parent holds the child's hands while the provider uses a gloved hand to look into the mouth. This is how dental hygienists often examine children. First, you want to lift the lip. Look at all the teeth, front, back, and sides. Note plaque, white spots, cavities, abscesses, and damaged teeth. Palpate the palate to rule out submucosal clefts. Healthy teeth should be a creamy white color with no signs of deviation in color, roughness, or other irregularities. If the clinician cannot determine whether an abnormality in the tooth surface is a defect versus an early cavity, this will not alter management. Any child with enamel abnormalities is at high risk for caries and should be referred to a dentist for further evaluation. Topical fluoride varnish is recommended to prevent decay and can be applied over caries or decay. ECC affects the teeth that emerge early and are least protected by saliva. Visualize a child sucking a bottle. With the child's tongue thrust forward, the maxillary incisors get maximal sugar exposure. Typically, ECC progresses in the following order. First the upper incisors, then the first molars, and then the second molars. Mandibular incisors, although they emerge first, are generally not affected because they are protected by the tongue and pooling of saliva in that area. White spots and lines are demineralized area of enamel and represent the first clinical signs of caries. Caries typically affect the teeth that emerge first and are least protected by saliva, such as the upper incisors. White spots and white lines typically begin at the gingival margin. If the disease process is not managed, the lesions will progress and the demineralized enamel will break down to frank cavities that initially appear pale yellow. Brown cavitations represent areas where loss of enamel has exposed underlying dentin. Anterior upper incisors are typically affected first as the posterior teeth have not yet emerged. Lesions are initially pale yellow and become progressively darker as they become stained with pigments from food. Teeth may be sensitive to hot and cold changes and sweet or sour foods or drinks. Most children are too young to articulate symptoms. Children with severe ECC require extensive dental treatment. Cooperative 4-year-olds with this kind of decay may be able to have the work done in the dental chair under the care of a dentist skilled in behavior management and treatment of ECC. Younger and less cooperative children will most likely have to be treated in an exam room under general anesthesia at substantial cost and risk. Multiple dark cavities appear in anterior and posterior teeth. It is possible for abscesses and draining fistulae to be present. Patients may experience pain. Mandibular incisors, although they emerge first, are generally not affected because they are protected by the tongue and pooling of saliva in that area. In these cases, we recommend urgent dental referral for comprehensive treatment, including extractions and/or silver crowns, dietary and oral hygiene counseling, and use of fluoride to prevent development of new lesions. All stages of early childhood caries require treatment. Treatment involves comprehensive dietary and oral hygiene counseling. Fluoride varnish is applied to arrest cavitated lesions and prevent development of new lesions. Urgent dental referral for comprehensive treatment is indicated. Some cavities may need to be restored using fluoride-releasing restorative materials. Lesions are small enough that simplified restorative techniques not requiring local anesthesia or high-speed drills can be used to stabilize their progression. Severe disease may require extractions, fillings, and root canals.
Oral health risk assessments should begin at age 6 months and be conducted at each well visit or dental visit. There are several risk tools available nationally. No tool has been validated enough to secure a recommendation from the U.S. Preventive Services Task Force. Risk assessments can help stratify future management. The American Academy of Pediatrics has a tool that has been found to be easy to implement, does not disrupt routine well child visits, and can be done in approximately 2 minutes. The results are an increase in dental referrals for high-risk children. A risk assessment tool should document risk factors, protective factors, clinical findings, level of caries risk, urgency of a dental visit, and depth of nutritional and hygiene counseling. This slide shows risk factors. Note that the caution sign is an absolute risk factor, such as primary caregiver with active tooth decay or primary caregiver does not have a dentist. Protective factors reduce risk and include having an existing dental home, use of fluoride water or supplements, fluoride varnish in the past 6 months, and routine brushing twice daily. It is important to document clinical findings, and again, certain findings that have a caution sign are absolute risk factors, such as white spots or demineralization, obvious decay, or restoration or fillings. After assessing the risk factors, a provider can weigh the protective factors versus the pathologic factors to decide the need for more urgent care or greater need for oral health education.
This is an example of the risk assessment uploaded into the Maine Medical Partners electronic health record, EPIC. The risk assessment can be uploaded into your electronic health record. There also needs to be documentation for the following: if the fluoride varnish was applied, if fluoride supplements were prescribed, if the child was referred to the dentist.
The use of fluoride, both through dietary and topical applications, has led to the dramatic decrease in caries rates. Fluoride helps prevent dental caries through topical mechanisms. It works by slowing the breakdown of the outer layer of the tooth, rebuilding the tooth's outer layer, and killing caries-causing bacteria. Topical fluoride is the most beneficial and is obtained through fluoride toothpaste, fluoride varnish, as well as gels, foams, and mouthwashes. Fluoride's strongest benefit is from topical contact with the tooth in the form of fluoridated water or supplements. There may also be some benefit from swallowing the fluoride and having it present in saliva. There is strong evidence supporting many preventive interventions that can be implemented as part of primary medical care. In May 2014, the United States Preventive Service Task Force issued new recommendations on fluoride use among primary care clinicians for children from birth through age 5. The task force found that the moderate potential benefit of fluoride varnish and fluoride supplementation outweighs the potential harm of fluorosis in children from birth through age 5 years. Here's a summary of fluoride use recommendations. Note that fluoride toothpaste and fluoride varnish are recommended for all children starting at tooth emergence. All children should receive fluoride through systemic water fluoridation or dietary supplements. Children who drink optimally fluoridated water should not receive supplements. Over-the-counter mouth rinses should only be used for children at high caries risk and starting at age 6. Fluoride is a very safe and effective agent. However, care needs to be taken to minimize the risk of fluorosis. Fluorosis is due to chronic excessive exposure to fluoride during tooth development. It can result in color changes or, less commonly, surface irregularities of the teeth. Chronic high-level exposure to fluoride can result in skeletal fluorosis, but fortunately, this condition is extremely rare in North America. Fluorosis does not weaken the teeth. It can be prevented by being clear on fluoride prescriptions, monitoring closely toothpaste amounts, keeping toothpaste in a safe place, and checking water for fluoride levels before starting supplements.
Let's look at the benefits of fluoride varnish. It is safe, inexpensive, and effective, not associated with treatment-related adverse events in young children. It is quick and easy to apply. Children can eat and drink immediately after application. Studies show that it reduces caries by 30 to 35%. It strengthens the enamel and can stabilize and prevent advances of ECC and slow enamel destruction in active ECC. The United States Preventative Services Task Force in 2014 recommended that primary care clinicians apply fluoride varnish to the teeth of all infants and children, starting with the appearance of the first primary tooth through age 5, at least every 6 months. The recommendation applies to all children, no longer a risk-based recommendation. All children should receive a professional fluoride treatment at least every 6 months in the primary care medical home. Higher risk children should receive fluoride varnish application every 3 months. Fluoride varnish is a Grade B recommendation by the United States Preventative Service Task Force. Preventative services given A or B ratings must be covered by new and individual insurance plans of all types, and by Medicaid and Medicaid-managed care with no cost sharing.
Providers can consult with state health departments to determine coding requirements and reimbursement rates. All states currently reimburse for fluoride varnish.
Let's discuss the application of fluoride varnish. To prepare, you will need to assemble gauze, varnish, and a good light source. Place the child in the knee-to-knee position. You can then check the child's mouth for developmental defects, white spots or cavities, oral health status, soft tissue pathology, and submucosal cleft palates. The child may cry during examination. The child does not open his or her mouth. Slide your finger into the buccal sulcus inside the child's lower lip on the outer side of the teeth and gums and apply gentle opening pressure. All findings should be recorded. A variety of 0.25 milliliter 5% sodium fluoride unidose fluoride varnish preparations are commercially available in the United States. Pricing information is based on average costs when purchased through distributors and is subject to variation and may be less when purchased in bulk. Each product and applicator system has its own unique advantages and disadvantages, and taste may vary. We do not endorse any particular product. Unidose fluoride preparations come in 0.25 milliliters, 0.4 milliliters, and 0.5 milliliter sizes. Clinicians should ensure that they use the 0.25 milliliter size for use with preschool children. To apply fluoride varnish, use gauze to blot the teeth as much as possible. You can wipe teeth from one side to the other in one constant motion with gauze held around the teeth. Varnish does not adhere well if teeth are wet. Apply varnish to dried teeth starting in the posterior. Apply a thin layer to all tooth surfaces with a brush. Apply varnish to anterior teeth last. This is the ideal order that may need to be modified if a child is active and uncooperative to ensure the high-risk anterior teeth are not missed. Saliva contamination after the application is fine as varnish sets in contact with saliva. After the application of fluoride varnish, tell the caregiver that the child's teeth may be discolored for 24 to 48 hours depending on the type of fluoride varnish used. We recommend no brushing until the next morning. Give your child soft foods for the rest of the day. Avoid sticky and hard foods. If varnish is applied for white spots or active decay, provide intensive counseling on oral health. The child should be referred to the dentist for urgent needs. Provide preventive advice to the parent or caregiver. You should emphasize the importance of regular toothbrushing, offer dietary counseling in regards to the amount and frequency of refined carbohydrate intake, provide systemic fluoride prescription if necessary, and refer the patient to a dental home. Please watch this short video demonstrating the proper application of fluoride varnish.
Fluoride varnish is a safe and effective way to prevent and control tooth decay. The U.S. Preventive Services Task Force recommends that all children from ages 6 months to 6 years receive fluoride varnish from their medical provider. In this video, we will demonstrate how to apply fluoride varnish in the office to very young children. Use the knee-to-knee position. Start with the child facing the parent with her legs on either side of mom's torso. Have the child recline toward you as the parent helps by holding the child's hands. Many providers will put the varnish on their glove between their thumb and forefinger for easy access. With gloved hands, secure the child's head and mouth with one hand. In one motion, use the other hand to dry the front and back of the top teeth using a 2x2 gauze. The teeth do not have to be completely dry. Apply the varnish starting from the back and moving toward the front. Continue across the entire arch. Repeat the process for the bottom teeth. Apply varnish to all surfaces of all teeth using a swift painting motion. It does not have to be perfect. As soon as the child closes her mouth or licks her teeth, the varnish hardens. Another option is to place the child on the examining table. The parent can help by holding the child's hands. Again, use one of your gloved hands to hold the child's head and mouth open. Hold the tongue out of the way with your fingers, but be careful to avoid being bit. For a child only with a few teeth, use your other hand to dry all of the teeth with the gauze. Then apply the varnish. Do your best to paint all surfaces of the teeth. Be careful to minimize varnish on gums and lips as it is very sticky. Also, avoid getting it on clothes.
In order to implement early oral health prevention in primary care, we recommend the following. Educate all staff, including front desk personnel, on caries risk assessment and the value of fluoride varnish. Train all clinicians on application procedures. Assign a varnish champion who answers questions, understands billing issues, assigns tasks, orders the varnish, and maintains exam room supplies. Divide the tasks amongst staff to avoid time burdens for one person. Store supplies in exam rooms or in a portable kit. Use a one-page form or electronic health record documentation that has checkboxes for risk history, consent, varnish documentation, advice, and referral. Update billing forms with varnish codes. Have copies of educational handouts ready to give to parents or caregivers.
To make care systematic and comprehensive, use this framework. Ask by taking a risk history, look and examine the oral cavity, decide on a plan, act with referrals, advice, and fluoride varnish as needed, and document all of this, ideally with prompts, in an electronic health record. Qualis Health has created 2 resources that can be found online with more details about oral health integration into the primary care setting and examples of practices that have done this.
It is important to advise families on strategies to prevent caries, such as diet, toothbrushing and flossing, toothpaste, fluoride supplementation, and the importance of establishing a dental home. For children under the age of 1 year, our recommendations are: strongly encourage breastfeeding, hold infant for bottle feeding, and avoid giving bottles at bedtime or nap time. Do not use sweetened pacifiers. Introduce a cup at 6 months and wean bottle by 12 months. Avoid the use of sippy cups unless it contains water. No juice in the first year of life. Snacks should have no added sugar. For children 1 to 5 years old, we recommend discontinue bottle at 12 months and limit juice to 4 ounces per day, and served only with meals. Avoid carbonated beverages and juice drinks containing sweeteners. Choose fresh fruits, vegetables, or sugar-free whole grain snacks. Only drink milk or water between meals. Limit meals to 3 a day, with 2 snacks in between. Limit soft drinks, candy, and sweets. Regular toothbrushing is important to remove plaque and food debris, and most importantly, for distributing the fluoridated toothpaste. Brush twice daily, beginning as soon as the teeth emerge. Bedtime is the most critical due to decreased salivary flow. Lift lip and brush along the gum line. Young children have difficulty brushing all areas. Parents and caregivers should continue to supervise brushing after children assume independence, usually until age 8 or 9, or once a child can write in cursive and tie their own shoes. The child should spit out, not rinse, after brushing to increase topical fluoride exposure. Excessive ingestion of toothpaste can cause fluorosis, which is a minor cosmetic problem relative to losing teeth to caries. In rare situations, such as consuming a large portion of a family-sized tube, systemic toxicity, including electrolyte abnormalities, can result in a medical emergency. Use a small smear of toothpaste for children less than 3 years old, about the size of a grain of rice. Apply a pea-sized amount of toothpaste for children 3 years and older, regardless of the caries risk. Most preschool children swallow much of the toothpaste placed on the brush. These guidelines take this into account, and these amounts are safe to swallow. Spitting out should always be encouraged. Parents should keep toothpaste tubes out of the reach of small children.
The United States Preventive Service Task Force and the American Academy of Pediatrics recommends primary care clinicians prescribe oral fluoride supplementation starting at age 6 months for all children whose water supply is deficient in fluoride, not based on risk assessment, until age 16. Dietary fluoride supplementation by prescription for children who do not have access to optimally fluoridated water is recommended by the American Academy of Pediatric Dentistry and the American Dental Association. Prescribe dietary fluoride supplements to all children who lack access to optimally fluoridated water, not based on risk assessment. It is important to determine your patient's source of water and its fluoride content before prescribing fluoride supplements. Test well water before prescribing systemic fluoride. In Maine, there are areas of naturally occurring fluoride. Fluoride supplementation should be given in liquid or chewable form and should be used at night. It is important the liquid is put onto the teeth and that the pill is chewed to get the greatest benefit from the supplement. Most of the benefit of supplements continues to be topical, although some is systemic. Supplementation should be given at night after brushing and not with milk products.
In our communities, there are many patients on Medicaid and many who lack any insurance. Some have no access to dental care. If your patients have limited dental care access, you may need to stratify the risk of the child. For children at moderate or high risk, assist parents in accessing dental care. Follow low-risk children in the medical office. Provide anticipatory guidance. Assess the need for systemic fluoride supplementation and prescribe appropriately. Regularly assess the patient's oral health. Provide dental referral when necessary and no later than age 3.
This concludes our training today. Here are the key messages we hope you take away. ECC is a significant health problem for children. As a primary care provider, you can play a key role in preventing ECC. Fluoride varnish is one part of a comprehensive approach to a child's oral health. It is safe and effective. You can apply fluoride varnish to a child's teeth as part of routine care. Thank you for participating in this training from Smiles for Life. We appreciate your role in keeping kids in the United States as healthy as possible. Thank you.